Angie, did you already make Dr. Fatoki co-host? Is that what you said when you first hopped on?
No, but I am right now. Thank you for the reminder.
Sure. So I think he has some slides we'll share. Marianne, I never had a chance. I apologize. I didn't thank you sooner for those Narcan signs that you sent a while back.
Yes, were you able to place them, all of them?
Yes, we definitely gave
That's
some to
terrific.
some coworkers. I know a couple gentlemen actually put them out in front of their homes too. They live in more highly populated areas, so I appreciated that.
You know, one of the things that happened, one of my colleagues put one in her front yard in a neighboring city. And not too long after that, some guy, obviously high, just walked into her house and it was unlocked because she was getting ready for work.
wow.
And she just let her dog out. And he just kind of entered the house and looked lost and
Really? Like he could get it
said,
there?
I think he might have been looking for Narcan.
Yeah, sounds like it. I was worried at first that it was gonna take a different direction when you said he walked in, but
No, he walked outside the back into the backyard and then went to the neighbor's yard, and he's a retired Marine and he came out with a gun.
oh boy.
And then they called the cops and the cops said, yeah, we found him this morning sleeping and we told him he had to stop sleeping on the street. And so I think they ended up arresting him.
Oh,
Yeah. But that thought never even occurred to me that, uh-oh, they were
yeah,
in trouble.
yeah. I mean, at least it was noticed, you know. I'd like to think some part of his mindset was, you know, seeking help.
Right. Yeah. Hopefully.
Yeah.
Hey, Angie, by the way, I have to jump off at 3:30. I have at 4. I have a supervision appointment at 4.
Great. Thank you, Marianne, for letting us know.
Sure.
Okay, I've got 3:31 here. Maybe give it 30 more seconds just to respect everyone's time, and then we'll start with introductions and then introduce our guest speaker. Doctor, you should have co-host privileges if you did have any slides or presentation that you wanted to share. We'll get there as soon as we finish introductions here.
I have slides, so hopefully they'll be helpful.
I'm sure they will be. Looks like a couple more have jumped on, so we'll go ahead and start. Good afternoon, everyone. My name's Dan Sokulski. I'm a recovery support specialist with Chestnut Health Systems, and I also help Angie with the McLean County ROSC. Most of you I know and know me as well. So just want to say we appreciate your time, and those of you taking a little bit of slice out of your busy schedules to spend the next hour or so with us. We'll go ahead and jump into introductions. Let's say your name, the agency you represent, or if you're a person with lived experience, and either a highlight over the last few days or week, or somebody you've been able to help. So Angie, can I start with you?
Sure. Good afternoon, everyone. Angi Chasensky. I'm the ROSC project coordinator, but I'm also a person with lived experience. And I would say someone that I was able to help is through a different type of support group, connecting them to supports outside the Chicagoland area and talking them through some situations.
Thank you. Let's go Don, and then Mary Ann, and then Jeanette.
Hi, I'm Don Mahana from Integrity Counseling, and I guess I'll do a highlight, which is that Luella and I just had our first time away from work here after all of 2020. We spent a few days down in Tucson, Arizona. So we're just getting back into swing now after having been gone for a few days.
Welcome back to the weather.
I think I go next. Good afternoon. I'm Mary Ann Drainer, and I work for Chestnut Health Systems, and I'm a prevention specialist. So I never really know if what I'm doing is worthwhile or not. Immediately, anyway. So.
Thank you, Mary Ann. I'm sure it is. And Jeanette?
Hi, my name is Jeanette Harris. I am new to a recovery specialist position through Chestnut for the Logan Mason County ROSC. I guess my work highlight is I work with some rock stars. Okay, I just want to say that, like, I get pumped every time we have a chance to get together and connect, because when someone is speaking your language and has your heart, to back it up, is just awesome. So that's my highlight. My personal highlight, though, is y'all, Friday, I'm headed to Puerto Rico. So I'm excited. I am excited. So that's me.
Thanks, Jeanette. And let's go Jessica, and Bruce, and then Lakeisha.
All right. I'm Jessica Jackson. I work for Heartland Community College as a therapist, and the highlight was commencement last week. So that's always really exciting, especially when you've known some of the students a while, because I'm not going to date myself, but some of them I've known years and years and years ago. And so it's so awesome to see them achieve a goal.
Thank you,
Bruce
Jessica.
Lang, I'm a board member of Prairie Pride Coalition, and I am the surviving partner of 12 years for a non-recovering alcoholic.
Any highlights this past week or so, Bruce? All right, we'll move on. Let's go Lakeisha and then Tony.
I'm Lakeisha. I'm from the Bloomington Housing Authority. I'm the Resident Services Coordinator. My highlight for this week is my organization, Empowered to Create. We had our first virtual youth day, and we had children from all over the United States participate.
Wonderful.
Hi, I'm Tony Randall. I am the community health specialist working on the ROSC grant in Bond County for Chestnut Health Systems out in Northgate. We are brand new to having anything in Bond County. We've had 2 ROSC meetings so far, so I love to come and see what other people are doing. I guess that I'm also a person with lived experience, not personally, but my son. And I don't know that it's a highlight, but it is a focus this week. Tomorrow will be the 2-year anniversary of losing my 21-year-old son to an overdose. So I do my work in his memory.
Thank you, Tony. Appreciate you being open with us and sharing that. Dorothy, Chantel, and then Randy.
My name's Dorothy Davis. I'm the Regional Coordinator for Parents Care and Share in the Central Region at Children's Home and Aid. My highlight was I had an awesome Blue Bow month, and you all that helped me, I really can't thank you enough. It was the best ever, considering we did almost everything on social media. So I'm still riding off those coattails right now. So thank you.
Thanks, Dorothy.
I'm Chantel Hunt. I'm coordinating intake for iGirl Services for home visiting doula services. And I was just thinking about this, and what I want to say is that I have a great group of, people in my corner who's been so supportive of me and what I've been going through. 2 of them is in his room, my girlfriend Angie and Miss Dorothy, my PIC. And so I just want to just highlight them for just being real supportive and keeping me positive and keeping my head above water with everything that's been going on.
All right, I'm Randy Wilson. I'm relatively new at Chestnut. I'm a community health specialist through the Regional Leadership Center. So we're still figuring out our whole area, but it's going to be all across Central Illinois, which is exciting. Getting to learn all the different organizations that there's so many throughout Central Illinois, especially in McLean County. This past week, I got to help out at a prevention event called Hidden in Plain Sight in Lincoln. So we actually went out into the community and hosted this event. So it was great that was my first community event through Chestnut. I didn't help planning it, but I helped facilitate. So it was an excellent experience getting to teach people in the community.
Thank you, Randy. Let's go Carrie, Joan, and Michelle.
Good afternoon, everyone. My name is Carrie Knapp, and I am also a community health specialist with Randy with the Regional Leadership Center project as well. So I am entering into my 4th week here at Chestnut, so I'm relatively new. So I would just generally say that one of my biggest highlights has been completing all of my trainings and getting to kind of know what this position will specifically entail. But our team is slowly growing as well as we're adding new team members. So I've been able to just kind of gradually meet some new faces, and that's really exciting to start building those connections.
Thank you, Carrie.
Hi, I'm Joan Hartman. I am a person with lived experience, and I also work for Chestnut Health Systems. And I also work for Heartland Community College. I'm one of the instructors for the new Peer Recovery Support Specialist Training Program.
Thank
Now,
you.
this week, I didn't do anything but take care of myself this week. I just got back from Texas seeing my family down there. So
That's a highlight. Thank you, Joan.
And I'm Michelle Cope from the Bloomington Public Library, and I do all things outreach and community engagement. I am a child of someone, a recovering addict, and just know what that family situation is like. And my highlight this week was just actually making 2 really great connections in the community to help them with the library services and with people I know, which includes you. So thank you for being part of my network that I can recommend to people.
Thank you, Michelle. Let's see, my screen jumped a little bit, but let's go Emma, Tony, and then M. Gray.
Hi, I am Emma Guevara. I'm an employment specialist at Bridgeway. Excuse me. And I would say my highlight was I just got back from extended weekend in Louisville. So just feel refreshed after that.
Thank you, Emma. Tony, did you already introduce yourself? Yes, you did. Thank you. Okay, I thought so. So let's go Ms. Gray and then Kristen after that.
Hi, I'm Kay Gray with TASK, Treatment Alternatives for Safer Communities. I'm a reentry case manager that works with offenders that are released from Sheridan and Swick, and I cover McLean County and Vermilion County. So I'm pretty excited to be a part of this. I don't necessarily have any highlights for this week, but my highlight from last week was I graduated from Illinois State University with my master's degree.
Absolutely. Great job.
Thank you.
Let's see where we're at here. Taylor, Angelica, and Jeremy.
Hi, I'm Taylor Davis. I'm the behavioral health specialist at McLean County Health Department. And highlight, I'm doing my first time car shopping, like official adult car shopping. So it's been fun.
Congratulations.
My name's Angelica Adcock. I run the First Aisle program at Chestnut Health Systems. My dad is in recovery from alcoholism, and I'm a person with mental health issues. My highlight is it's going to be my 2 years at Chestnut on Thursday, which is kind of shocking to think that I've been working at a job so long, but then also I've been out of college for 2 years.
Thanks, Angelica. And Jeremy, did we lose him?
No, I'm here. I'm good.
Okay, there you are. Moved on me again.
Hi, I'm Jeremy Studebaker. I am actually, I work at Chestnut, but I work in the Lighthouse Institute, which is the research division of Chestnut Health Systems. So do a little bit different than what everybody else is doing here in the Chestnut family that we have. And I would say our highlight is we're doing a research study right now, and this week we have probably about 12 or 13 intakes and follow-ups that we're doing. So my highlight will be Friday when everything is done. So mine's kind of like a pre-highlight to what's going on right now. Thank you.
Thanks, Jeremy. And a few more, Natasha, Tom, and then Taylor.
Hi there, my name is Natasha Nunu Ponder, and I work at the McLean County Center for Human Services. I am the Community Integrations Coordinator in the Recovery Program, where we work with chronically and severely mentally ill adults. My highlight over the last week is I was vacationing in Ghana for like 9 days, so that was a pretty big deal.
Absolutely. Thank you, Natasha. Mr. Trove.
And yes, this is Tom Trow. I'm the Regional Recovery Support Specialist for DHS Division of Mental Health. I'm officing in my home in Peoria Heights yet, and probably I survived the last 2 weeks, and the biggest thing is we have all the training modules now complete, ready to start being distributed. Some of you might even gotten the first two for this summer's CRSS and CPRSS competency training. So watch your mail. Thanks.
Thank you, Tom.
Hi, everyone. I'm Taylor. I'm with McLean County CASA, and something that is exciting is today is National CASA Volunteer Day, and it's the first year that this has been put in place, so it's very exciting.
Thank you, Taylor. Kristen, looks like we got you back.
I'm here. I'm Kristen Manzi. I'm a behavioral health consultant at the Chestnut Family Health Center. I've worked here total about 2.5 years. I know a lot of you on here. What else are we sharing?
Just a highlight over the last week or so.
Let's see. A highlight for me is we finished our walls and ceiling and floors, and my family is no longer living in one room in the basement because it was a little stressful.
Sounds like
I'm
a
very
highlight.
proud of our efforts.
Hey, Dan, I just want to, I just noticed something. Michelle Cope, I did not realize she was in the room, so I got to give a shout out because that's my other girlfriend who's been my support. So I definitely, when I saw her, I'm like, Michelle, no, I couldn't leave her out. Sorry about that.
Michelle, your bell. We all love Michelle. Okay, and there's somebody I have not asked to introduce himself because I'm going to take the honor of introducing him in just a second. But I'd be remiss if I didn't share a couple of highlights over the last week for myself. 1, White Sox have moved into first place. 2, my favorite band announced a fall tour. So after waiting 2 years, finally get to take the family to see another show and meet up with a fellow college friend who's also sober. And on the 11th, last Tuesday, I celebrated 6 years of continuous sobriety. So it was a good week. Okay, I want to read some, just if you all bear with me, I'm going to read just 2 paragraphs out of the big book of Alcoholics Anonymous, and that will be a little segue into a brief bio I want to read about our guest speaker, and then we'll get to our presentation. It says on page 133 in The Family Afterward, now about health. A body badly burned by alcohol does not often recover overnight, nor do twisted thinking and depression vanish in a twinkling. We are convinced that a spiritual mode of living is a most powerful health restorative. We who have recovered from serious drinking are miracles of mental health, but we have seen remarkable transformations in our bodies. Hardly one of our crowd now shows any marked dissipation, but this does not mean that we disregard human health measures. God has abundantly supplied this world with fine doctors, psychologists, and practitioners of various kinds. Do not hesitate to take your health problems to such persons. Most of them give freely of themselves, that their fellows may enjoy sound minds and bodies. Try to remember that though God has wrought miracles among us, we should never belittle a good doctor or psychiatrist. Their services are often indispensable in treating a newcomer and in following his case afterward. That's one of my favorite pages in the book, you know, when I just think about the different doctors and the question that clients often have about taking medication in recovery and if it really means they're sober and that kind of stuff. And it, you know, tells us right in our book that we need to seek these people out because of their gifts. And Dr. Fatoki is one of those people. I met him as part of my own recovery journey as a patient 6 years ago or so. And you know, as I grew into my role in Chestnut, we've kind of developed more of a relationship, I guess, on a professional basis. I'm by no means a doctor, but you know, we have a lot in common. And this is about 2 years in the making, getting him to appear at a ROSC council meeting. And we feel with the reentry discussions we've had recently that the timing is right. Dr. Fatoki graduated from University of Illinois in the College of Medicine in 1990. He's board certified in family, bariatric, and addiction medicine and the co-founder of the Practical Weight Management Program. He became interested in dealing with bariatrics due to his own struggles with weight in the past and poor advice that was prevalent in the field. He has two practices, one Great Heights Family Medicine in Ottawa and another in Calumet City. Those are family practices. He has over 32 years of experience in the medical field. He studied under addiction icons in Illinois, such as Mark Sanders, who happens to be our McLean County ROSC coach. His practice includes specialization in medication-assisted recovery or medication-assisted treatment, more commonly known recently. So medications like Vivitrol, Sublocade, Suboxone, Buprenorphine, Methadone. Another special thing about Dr. Fatoki has been extremely active in bringing medication-assisted recovery to jails throughout Chicagoland. He's been a huge advocate for helping people on their road to recovery while incarcerated in order to help with reentry by reducing relapse and recidivism. He's definitely done more than anybody I know to help with jails becoming more aware of this issue and single-handedly probably helping jails change their policy about a lot of this stuff. In his free time, he enjoys his family and plays in competitive volleyball leagues. And with that, I would like to ask you all to please help me welcome Dr. Adeyemi Fatoki.
Thank you, Dan. I didn't think this was a big meeting like this, so I'm pleasantly surprised. But I'll try and hopefully stick to the points. I guess I should tell you my highlight for the week also, and I'll tell you something about myself. So my highlight for the week is that I got to give the closing remarks at the Masters in Addiction Studies graduation at Governor State University on Thursday. So that was the first time I had been invited to do such a thing. And the second highlight is being able to do this talk for you today. So thank you, Dan, for the honor to be here. I'm trying to see where to start, but I guess I'll tell you something about myself first. I got involved with treating addiction by default. In around 1998, I started working for a company called Adults Healthcare in the jails. And then another company called HPL that was based in Peoria took over. But one thing I realized is that a lot of the patients that I saw at the jails, well, I guess the first thing is I started working out in the juvenile system. So a lot of the children who had major surgery, including appendectomies or had fractures, they actually would only call they'll only come for the pain medications maybe for like a week. And after that, they'll stop coming to the healthcare unit to obtain the medication. So then I started thinking if all these opioids that were being prescribed were really necessary. And then the second thing I noticed is that while the patients are in jail, there's really nothing to rehabilitate them. You know, there is no vocational training. all they do is just hang out all day with nothing to do. And my first thought is, if these people are in here, you're not treating them, of course they are going to be right back. We are not helping them in any way. And that's what piqued my interest in addiction medicine. The other thing I realized too is that the patients do extremely well while they're in the jail, but once they go out, they relapse within a short time. And I'm starting to think, okay, it's like putting someone in the hospital to control their diabetes, and then you send them home without any medication or insulin. Of course, they are going to get sick and they'll be right back. And there was one time when I was working at the jail in Wisconsin, one of the patients, like the first few weeks she was there, she gave me the hardest time. And then once she was detoxed, she was stable and doing well, I realized she was just a normal person, just like I was. I mean, assuming I'm normal. We could have conversations and just talk about different things. So she was there serving a 6-month sentence. When she got released, the same day she was released, they call it Huber in Wisconsin, which is a work release program. They go out to work, then come to the jail at night. The same day she was released, she was found in her car after suffering an overdose. Fortunately, she was able to be revived. And when she came back to the jail and I asked her what happened, you did so well in here for 6 months. And her response was, well, in the jail, you guys controlled everything I did. But outside the jail, I just can't control myself. And that highlights the way that I look at addiction. I would like to share some slides with you to see that let me see if I can share my screen with you. Sorry about the phone. Can you see the screen?
Yes.
Okay, so let me just go over some of this and then we'll talk about some personal things here. So I don't have any financial interest in any of the products that I'm discussing or anything that we say today. And I'm not here representing my employer, which is WellPath. That's who I work the jails for. But I also have my own private addiction practice. So, and I don't mean to like go too basic. I know most people here are involved in recovery, so I'm not really sure how much information you need. The definition of addiction is that it's a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. So if you look at it this way, the addiction will not only apply to drugs, it could apply to anything. It could apply to gambling, it could apply to relationships, it could apply to shopping. So anything that would cause a compulsion, even though you know that it's going to cause you adverse consequences and you keep doing, is more or less an addiction. And I look at them as demons. So that's the term that I prefer to use, is that it's a demon, but we all have demons. And the better we're able to control those demons, the better off we are. So addiction is considered a brain disorder because it involves functional changes to the brain circuits involved in reward, stress, and self-control. And this is a problem that a lot of people had difficulty accepting, including myself. But again, over time, the science has shown that there's a genetic and environmental cause for addiction. So this is a picture that I like to reference. And you can see the red is the dopamine levels in the brain. So the first one on the left is a normal patient. And then the middle one is a patient who has been using cocaine. So you can see how the red in the middle disappears completely. And then on the right, this is 4 months after the last cocaine use, you can see it starting to come back. And this may take a long time for the brain to return to normal. In some cases, it may never return to normal. So addiction is multifactorial. It has to deal with both the genetic and environmental factors. Epigenetics is what describes the way that our genes interact with our environment. So 40 to 60% of a person's risk of addiction is due to their epigenetics. So this slide here shows the biology between the genes and the environment leading to drug abuse. So you have the genetics, you have the gender, the mental disorder, and on the right, the environmental factors, a chaotic home abuse, childhood trauma, parents' use and attitudes, peer influence, community attitudes. Those all lead to drug addiction. And then, to drug use, then the break mechanisms, and then to addiction. So some risk factors for addiction include aggressive behavior in childhood, lack of parental supervision, low peer refusal skills, drug experimentation, easy availability of drugs, and community poverty. On the right-hand side, you see the protective factors. Those include belief in self-control, parental monitoring and support, positive relationships, extracurricular activities, school and anti-drug policies, and neighborhood resources. So in the US, most people that are incarcerated do not receive the treatment that they should for drug addiction. So only about 14% of the inmates are offered buprenorphine, 55% are offered methadone, and more than 50% of those only offered methadone for pregnant women. It's a whole lot cheaper to treat people for addiction than it is to pay for incarceration. As you can see, the cost of incarceration is about 5 times higher than the cost of treatment. So addiction is a chronic illness, and the things to compare, it's not curable. At least at this time, we don't have a cure. It's chronic, it's prone to relapse, and it can be managed. And if it's not managed, it can lead to severe morbidity and mortality. So if you look at any other chronic illness like hypertension or asthma, they are similar to addiction. So when you treat, the severity goes down, and then when you stop treating, it goes up. So when I first got into addiction treatment, the way we looked at addiction was that it was a moral failure and that the patients lacked control. But the recent thinking is that it's a chronic brain disease. So I'm going to tell you something personal about me for a few minutes here, just to say the way things are. So one of the problems that I had was for some reason, I got into bad relationships. Before I get into the relationships, I already know what it's going to, or where it's going to end up. Because again, I know the person is not good for me. We argue all the time. We don't have too many things in common, and it's just a toxic relationship, but I still do it anyway. And it was so bad that my mother used to tell me all the time that she couldn't understand how I could be so smart and dumb at the same time, But then I remember one time when my brother and I got into an argument, and he told me, I was just irresponsible. And the question I asked him and myself is, why do you think I would like to ruin my own life? Why do you think I want to get into these relationships, knowing that it's going to end up bad, then I'm going to end up having to pay child support or having to pay alimony, and then I have to start all over again. I mean, it never makes sense why anyone would purposely choose to ruin their own lives. And then, like some of the relationships after they end, then there might be days when I'm sitting at home bored, and then I'm looking at my phone and thinking, well, should I call this person? Maybe I shouldn't. Should I call? And those are the things going on in my head the whole time. And then eventually I'll end up picking up the phone. I call, we get back into the relationship. Then I start hiding from my family. I don't call them. And then when I get my nose bloodied, I run right back home to my family. And that's when I realized, oh my God, I'm behaving just like a drug addict. It's the exact same thing, because the patients that I work with, they're thinking about doing the drugs and they don't want to. But again, it doesn't make any sense to me that anyone would purposely want to ruin their own lives. So this quote is from the Bible, and it says, I have the desire to do what is right, but not the ability to carry it out. For I do not do the good I want, but the evil I do not want is what I keep doing. And that's what I see with addiction, or the demons that many of us have. Our patients know the right thing, they want to do the right thing, but again, there's just something that's stopping them from doing what they want to do. Why would someone want to go to work all day, especially the patients I have that are in a labor union? They work very, very hard. And there's someone just sitting around waiting for them on payday. And all the money that they made that they plan to use to pay their bills, pay for their kids' education, buy something for their spouses or for their parents, they just give all that money away to a drug dealer. It never made any sense to me. And that's when I started realizing that, you know what, this is something beyond people's control. And really all the medication does, and that's the way I explain it to my patients, it just calms the brain down enough for the patient to make the decisions that they already know they need to make. So sitting around and scolding someone when they already know what their problem is not helping them in any way. So I'll go back to the slide. We talk about the effects of incarceration on an individual. It affects their emotions. It's a disruption of the family. Many times people are in despair because they don't know what's going to happen. And all these emotional and psychological problems lead to physical complaints. So you have patients that are complaining of pain and shortness of breath and things related to anxiety. And for patients who have an addiction, the substance abuse is an independent risk factor for suicide when they are incarcerated. So when someone uses drugs chronically and acutely, it can impair their judgment, weaken their impulses or their impulse control, interrupt the neurotransmitter pathway leading to disinhibition. And the risk of heroin by itself increases of the risk of suicide the use of heroin increases the risk of suicide about 13 times more compared to 10 times with alcohol use disorder. As far as benzodiazepines and alcohol, the time that I've worked in jails, we've always taken those seriously because a lot of patients who are withdrawn from alcohol or benzos, the risk of them going into DTs or dying is high, so we always took those serious. But when it came to opioids, the attitude that a lot of the staff and the providers have as well is just like getting a bad case of the flu and the patients will be okay. But we realize now that that is not the case. Like patients do die from opioid withdrawal or commit suicide from it. So some of the things to look at, a lot of the jails, the patients come in on their medication, like they might be on Suboxone or Methadone, and the first step is to stop it because the jailers don't want any controlled substances in the jail. But we don't do the same thing when it comes to their medication for hypertension or for asthma. So one of the things that we need to fight for is for the patients to be able to continue their treatment. Because again, incarcerating someone is not the same thing as treating someone. You could lock someone up and not let them have access to the things that they want. But as soon as they go out, they are going to go indulge in those things, and the consequences might be a whole lot deadly because they're more or less opioid free if they haven't used any opioids for a few months or weeks, but that's not treating the chronic brain condition. So there are 3 classes of medications that are approved for opioid use disorder. The things we need to realize is that one medication does not fit all, and that the patients do have a choice in whatever treatment that the physician recommends. So if I'm recommending that someone goes on methadone, if they don't want to be on methadone, I can't force them to be on methadone. So methadone is the drug that has been around the longest. So it's been the standard of care since the 1970s. So all the medications that are approved are tested against methadone. So they had to at least be as effective with no more severe side effects that methadone will provide. Because of the risk associated with overdose, with the induction of methadone and its use, in the US, it's only approved to be used for opioid use disorder through an opioid treatment program. The ironic thing is that physicians can prescribe methadone for pain, but when it comes to treating addiction, it can only be used or prescribed by an OTP. Buprenorphine is newer. It's been the standard of care since 2002. It's a whole lot less restricted than methadone. It can be prescribed by an ex-waiver provider, and the risk of overdose is less. So going back to methadone, methadone is a pure agonist. So you could technically keep on increasing the dose. And that's why I guess a lot of people are leery about using it. But what I tell my patients is that if the dose is right, you shouldn't be falling asleep and you shouldn't be having any cravings. So most patients will stabilize on methadone between 60 and 100 milligrams a day. For buprenorphine, it's what's considered an agonist and an antagonist. So it's got both the effects of a blocker as well as the same kind of effect that you get from a pure opioid. The advantage of that is that at about 24 milligrams, more than 96% of the opioid receptors in the brain are blocked. So it's very, very rare that you have to go above 24 milligrams. And also that makes the risk of overdose a whole lot less compared to methadone or pure opioid medications. So naltrexone was first developed for alcohol use disorder, but then it's been marketed effectively in the correctional system. And one of the issues is that a lot of jails and prisons will try to use this as the only medication. It's the only one that they'll accept because it's a pure antagonist, and the risk of misusing it in the jail is less. But at the same time, one medication will not fit all the patients. So when Vivitrol is used as the only drug, you have some patients that it's not working for. The other thing is that because it's a pure antagonist, it's blocking the receptors. Once the patient stops taking it, then the risk of overdose is a whole lot higher. And from my experience, usually what the patients will do with Vivitrol is they know the medication will last about 28 to 30 days. They will skip their appointment so that they could use, then come back to the clinic maybe 1 or 2 weeks later. And Suboxone is the same thing, like the patients, when they get ready to use other drugs, they just stop the medication for a few days so that they don't have the blocking effect that it has. So naltrexone, the one that we are familiar with is the Vivitrol, which is a long-acting, but it also has an oral formulation that works better for alcohol. It doesn't do much for opioid use disorder. So when it comes to pregnant women with opioid use disorder, methadone is the recommended drug of choice, but buprenorphine is also safe to use. Naltrexone is not recommended in pregnancy. So some of the benefits of opioid use disorder is that it provides a stable intrauterine environment for the baby. It raises the chance of having a healthy baby and a healthy mother. There's a decreased use of illicit drugs, decreased overdose, and it is just the right thing to do. As far as my fight with trying to get the medication-assisted treatment into jails, one of the first inroads I was able to make was with the pregnant women, because the standard of care was either putting them on buprenorphine, which is on plain the Suboxone without the naloxone, or continuing them on methadone. So I know the jails that I went to, they tried other things like, give them Tylenol-3, give them Norco or detox them, but I was able to overcome that by letting my employers know and the jails that in my office, I wouldn't do that, So if a pregnant woman came to my office, I would either start them on methadone or buprenorphine, depending on their choice. And I wasn't going to do something that was not the standard of care in the jail because I couldn't defend myself in a lawsuit. Like the other providers who didn't treat pregnant women on opioids like I did, yeah, they might be able to get away with it, but I had no excuse, you know. So once I started fighting that route, they left me alone. So I was able to get the buprenorphine at least used for the pregnant women. So we have a program at LaSalle County that we started in 2019 with a grant from the state. It's the SOR grant, and we do work with Lighthouse. So the average daily population at the jail is 135. And this is an old slide, so we have more numbers than this. We've been using all 3 approved medications. Most of the patients that we treat on buprenorphine, we have a few that we've treated with methadone. But the one thing that we do now is that everyone who comes in who is withdrawing from heroin or other illicit opioids, we will detox them with buprenorphine for 5 days. Then after that, we'll talk to them and try to get them started on maintenance therapy. If someone came in on methadone or buprenorphine or Vivitrol, we'll continue while they are at the jail. Some of the challenges has been trying to get the jail staff, you know, to buy in and accept the treatment. You know, the attitude has changed significantly since we started, but a lot of, when we first started, the jail staff just felt like, oh, this was it was a waste of time. It's a money-making scheme, you know, which they didn't realize that this is just to help the patients out, and it's not really any way to make any extra money. The satisfaction that we get from doing the work we do is seeing patients do well, and also seeing how the families get restored. I also had a big problem with the probation staff. You know, they didn't want the patients on anything except naltrexone. But we had a meeting, we sat down and talked, and the relationship I have with the probation staff at LaSalle County is pretty good now. Like, they call me if they have a patient that's leaving the jail or someone that is not doing well. You know, sometimes we'll work just to violate someone for a few days so we can detox them and then get them into treatment. And they also allow me to help them decide what treatment is best for a patient. So rather than them insisting that the only thing they want is Vivitrol, they'll let me talk to the patient, and then between the patient and I will decide which medication the patient wants. Some of the difficulty with trying to get patients in treatment is that a lot of them mistrust the system. You know, you've had patients who have come to the jail in the past and have been allowed to withdraw or not allowed to continue their medication. So they don't really trust what they're saying. Then I have to convince them that whatever they tell me is part of their medical chart, and that's not going to be used against them when it comes to their charges, and that they could trust me because we don't share that kind of information, you know, when it comes to them going to court or their sentencing. So one of the issues that's a lot of people worry about in the jail is diversion. The thing to understand is that a lot of drugs that are not considered like hot commodities outside the jails are easily abused in the jails. So I've had patients who will snort on Tylenol. Seroquel is one drug that's commonly abused. Same thing with gabapentin. Gabapentin gives a high that's almost similar to what you get from benzodiazepine. And, you know, there's a combination of drugs that the patients will want to get. And when the patients start asking for a certain drug, or when everyone in the same cell start asking for a certain drug, then that's when it raises a red flag. You know, we've even had one of the patients who was on buprenorphine that she would act like she was taking the medicine, go back and spit it out when she got back to her room, and then dry it out, and then was selling it to the other patients. The way we found out was because one of the patients told on her, and then we drug tested all the patients in the pod, and about 5 out of 7 of them tested positive for buprenorphine that they shouldn't have been on. But again, the answer to that is treating the patients when they want treatment, just so that they don't continue abusing the medication. What we've done to mitigate that is to crush the buprenorphine It helps because the medication dissolves quicker, and then we also have them drink water after they take it to make sure that they don't have anything in their mouth. I forgot to mention that buprenorphine has to go under the tongue. That's the way it's effective. If it's swallowed, the digestive enzymes destroy it, so the medication is not effective. The risk of overdose is high within the first 2 weeks of release. And even after 1 year, the risk of overdose is still higher. So one of the things that we try to do is make sure that every patient that leaves the jail is prescribed naloxone or given naloxone. We do have some naloxone from the state. So what we do now is just put it in their property when they come in. So that way, even if there's no nurse on duty when the patient is going home, the jailers will give it to the patient. We try to refer patients to community providers. We encourage them to attend self-help groups and also help them with reactivating their medical coverage and obtaining ID cards. So I'll just take a few minutes. We still have a few minutes. Dan, is that okay?
Yeah, that's great, Doctor.
Okay, just to talk about some personal things. So I would, like I said, I had my own demons that I had to walk through, and I still walk through it on a regular basis. One of them is my weight. I love to eat, and I don't always make the best choices, so that's what got me interested in weight loss. But the other thing that I try to do is put myself in the shoes of my patients. Last year when COVID started, I talked to Dan about this. I was trying to see what I could do to give myself the best chance of survival. And I said, well, I'm going to make sure that I eat better and exercise every day. But I also wanted to know how difficult it is when I tell my patients to make a change. I'm telling them, block your number, don't talk to this person anymore, or find a new hobby, find something else to do. So I've always played volleyball, but okay, I decided I'm going to start closing my exercise rings on my watch every day. And I can tell you it was one of the hardest things I had to do. It's every time I think about getting on the bike, I have very bad headaches, my muscles tighten up in my neck, and it's just the most uncomfortable feeling. If I'm riding the Peloton for 20 minutes, after 5 minutes, I'm already looking like, when is this going to end? But the more I've done it, the easier it's become. And to the point now that I think I have 407 days that I've been closing those rings, because the way I look at it is if I sleep, it's like I relapsed. Even when I'm really sick, I'll still take the effort to go do the exercise just because I don't want to relapse. And that's what our patients go through every day. But again, it's a very difficult process, and we need to keep encouraging them to stick with it. Let me see what else. I'm looking at the email down to see what else we can cover.
I think that's great. We could probably, because I wanted to take a little bit of time just in case people have questions, or just want to follow up on anything. Is there also a possibility of receiving this deck of slides? If there's a couple of things as you're going through that I didn't quite catch that I wouldn't mind, like some of the statistics and that kind of thing. If you're able to share this, that would be, I think.
Yeah, I can email it to you and then you can share it.
Okay. Yeah, I think if you want to stop the screen share, maybe we'll just open it up for a little bit of discussion with some of the time we have. Wonderful, thank you. So a lot of ground was covered there. Does anybody have any questions or anything they want to, run by the doctor, ideas, just anything, we'll open it up. You kind of touched on this near the end there. One of the things I was wondering, knowing that you also treat patients for help with weight loss, some of the, what are some of the similarities between treating a patient for weight loss and versus substance abuse or substance disorder?
One of the things with making a lifestyle change is extremely difficult. And that's what I see as a similarity with weight loss, like trying to change your eating habits. You know what foods are good for you, what foods are not healthy. You know, trying to stay away from sugar, trying to exercise on a regular basis. And I have patients who tell me, well, I'm exercising a lot, I'm doing this, I'm doing that. But again, when you ask about what they're eating, you know, it's a lot of sugar, it's a lot of processed foods. But again, those are things that are extremely difficult to change. It's difficult to make lifestyle decisions, you know, that will help you. It's not like the patients don't know, they know. You know, we all know what we need to do, but it's just getting that motivation to do it. But the more we do it, the easier it gets. And it's just something that you have to stick with over time.
Thank you. Any other questions for Dr. Fatoki?
Dr. Fatoki, excuse me. Sorry, I'm gonna ask a quick question because I need to jump off. So I was just curious, overarching, I understand that you have your experience in the penal system with medication-assisted recovery treatment. How likely do you think within the next, you know, I would even say 3 to 5 years, do you see us gaining traction as that being a commonplace, you know, activity, and also not only in the penal and the jail system itself, but also in the community, how it's, you know, accepted as a common, you know, therapeutic intervention?
I see it becoming more acceptable, you know, and I tell my patients that every single one of us, everyone who is doing well is a recovery advocate, because when people see how well you're doing, it encourages others to do well and also to accept it more. One of the advantages we have in Illinois is that the state is very, very proactive in trying to get treatment into the penal institutions, you know, and I know there was a grant that was offered to the jails to learn more about medication-assisted recovery. So Illinois is really ahead of the game when it comes to trying to push treatment. And the other thing too that we have going for us is that a lot of the jails are starting to lose lawsuits when they do not allow the patients to bring in their medications. So things are definitely changing. So within the next 5 years, I think we'll be way ahead. You know, I've gone from telling my patients who are serving weekends in the jail, and again, that's one of the things that doesn't make sense to me. If someone is only coming there for 2 days, why would you stop the medication for 2 days for them to go right back onto it when they get out on Monday? You know, so those are things that we could start by changing first, because those really don't make any sense. I mean, whatever medication the patient is taking, when you're taking them off for 2 days, then you're really putting them at risk for relapse. You know, even if they're taking Norco or whatever, stopping it for 2 days is not helping the patient at all. You know, you might as well continue it since they're only there for 2 days and, you know, adjust it and go on. But I mean, I've had people that I've had to tell them, well, take your medicine, the jail won't let you in, I'll let you bring it in, take it before you go into the jail then.